My name is Stasha Hedgenakis, and I am pleased to present Chapter 35 of the 2018 Clinical Practice Guidelines on Type 2 Diabetes in Children and Adolescents on behalf of our lead author, Dr. Konstantina Panagopoulos, and our co-author, Melanie Henderson. Key changes in this version of the guidelines include recommendations around prevention strategies through limiting intake of sugar-sweetened beverages, improving sleep quantity and quality, decreasing screen time and sedentary behaviors, and increasing light and vigorous physical activity as per the Canadian 24-hour movement guidelines for children and youth. Changes have also been made to the screening recommendations, which now include a combination of A1C and fasting or random plasma glucose. There are also new recommendations for the initial management of children with type 2 diabetes who are metabolically stable. We will review epidemiology, prevention, screening and diagnosis, classification, management, immunization recommendations, complications, and screening for comorbid conditions. Type 2 diabetes in children has increased in frequency around the world for the last several decades. A Canadian national surveillance study demonstrated a minimum incidence of 1.54 per 100,000 children per year. We did notice significant regional variation, with the highest minimum incidence seen in Manitoba with 12.45 per 100,000 children per year. Large epidemiologic studies suggest that breastfeeding may reduce risk for youth-onset type 2 diabetes. Obesity is a major risk factor, and family-based lifestyle interventions with nutrition, activity, and mental health counseling have been shown to result in significant metabolic health benefits in children and adolescents with obesity, as well as a modest decrease in BMI. In adolescents with obesity, pharmacotherapy in combination with lifestyle interventions demonstrates a very modest additional reduction in BMI over the short term, but their role in the prevention of type 2 diabetes remains unknown. Bariatric surgery may be considered in adolescents with severe obesity who have reached their final adult height. However, the long-term effectiveness of bariatric surgery in adolescents also remains unknown. Screening and early diagnosis of type 2 diabetes in children and youth. Why is it worthwhile? Children and youth with type 2 diabetes can present with acute metabolic decompensation, such as DKA or hyperosmolar hyperglycemic syndrome, both of which are associated with a high degree of morbidity and mortality. At the same time, microvascular complications of type 2 diabetes have been identified at diagnosis, implying long-term and unrecognized hyperglycemia. This provides strong evidence for the benefit of screening and early diagnosis of type 2 diabetes in children and youth who are at risk. Risk factors for the development of type 2 diabetes in children include having a family history of type 2 diabetes in a first or second degree relative, being a member of a high-risk population, having obesity, being exposed to diabetes in utero, having evidence of acanthosis nigricans on physical exam, having a diagnosis of impaired glucose tolerance or impaired fasting glucose, polycystic ovarian syndrome, hypertension, dyslipidemia, or non-alcoholic fatty liver disease, and finally the use of atypical antipsychotic medications for the treatment of neuropsychiatric disorders. Screening for type 2 diabetes should be done using a combination of A1C and fasting or random plasma glucose. If there is a discrepancy between the A1C result and the fasting plasma or random plasma glucose, then an oral glucose tolerance test should be done. Diagnostic criteria for type 2 diabetes for children are the same as for adults. Diagnostic cutoffs for the diagnosis of diabetes include a fasting plasma glucose of greater than or equal to 7, a 2-hour plasma glucose in a 75-gram oral glucose tolerance test of greater than or equal to 11.1, or an A1C of greater than or equal to 6.5%. Screening for type 2 diabetes should be done in children who meet any of the following criteria, 1 through 4. Number 1, non-pubertal children with 3 or more risk factors beginning at age 8, or pubertal children with 2 or more risk factors should be screened. Risk factors include obesity, being a member of a high-risk population, having a first-degree relative with type 2 diabetes, or exposure to hyperglycemia in utero, having signs or symptoms of insulin resistance, including acanthosis nigricans, hypertension, dyslipidemia, or non-alcoholic fatty liver disease. Children and youth with any of the following conditions should undergo screening for type 2 diabetes. These conditions include polycystic ovarian syndrome, the presence of impaired fasting glucose or impaired glucose tolerance, or the use of atypical antipsychotic medications for the treatment of neuropsychiatric disorders. In those who continue to meet criteria, screening should be repeated every 2 years. In most children, the presence of clinical risk factors, mode of presentation, and early course of the disease indicate whether the child has type 1 or type 2 diabetes. However, differentiation may be difficult in some. Children with type 2 diabetes can present in DKA. Testing for autoantibodies should be considered in all children and adolescents with a clinical diagnosis of type 2 diabetes, as there is evidence that up to 10 to 20% of these kids will have autoantibodies present, suggesting that they in fact have type 1 diabetes with associated insulin deficiency and risk for other autoimmune conditions. In addition, the absence of islet autoantibodies may be useful in supporting the diagnosis of type 2 diabetes. Fasting insulin levels are not helpful at diagnosis. Fasting insulin may be low due to glucose toxicity. Genetic testing for monogenic causes of diabetes should be considered in children who have a strong family history that is suggestive of an autosomal dominant inheritance pattern and those who are lacking features of insulin resistance. Children with type 2 diabetes should receive care from an interprofessional pediatric diabetes healthcare team. Team members should include a pediatric endocrinologist or pediatrician with diabetes expertise, diabetes educator, and a mental health provider. These programs should address lifestyle and health habits for the entire family, emphasizing healthy eating and physical activity, promoting smoking prevention and cessation strategies, and also identifying and addressing any psychosocial stressors that are present for the family. Regular physical activity has a number of proven health benefits. Children with type 2 diabetes should achieve the same activity level as that recommended for children in general. This includes 60 minutes of moderate to vigorous physical activity and limiting sedentary or screen time to less than 2 hours per day. A significant proportion of youth with type 2 diabetes live below the poverty line or come from low-resourced homes. Psychological issues such as depression and binge eating are also common amongst this population. Addressing these issues will be critical for successful diabetes management. Insulin is required in those with severe metabolic decompensation at diagnosis, for example, diabetic ketoacidosis or initial A1C of greater than or equal to 9%, or symptoms of severe hyperglycemia. Insulin may be successfully weaned once glycemic targets are achieved. While none of the non-insulin anti-hyperglycemic agents have been approved by Health Canada for use in children, there are increasing data about the safety or efficacy of some of these agents. Metformin, for example, has been shown to be safe in adolescents for up to 16 weeks, resulting in a decrease in A1C by 1 to 2%, and lowering fasting plasma glucose with similar side effects as seen in the adult population. Glimepiride has also been shown to be safe and effective in adolescents for up to 24 weeks, reducing A1C by 0.54%, but also associated with a weight gain of 1.3 kilograms. Metformin is currently preferred over glimepiride in this population. In those with new onset type 2 diabetes who are metabolically stable, metformin should be initiated in conjunction with health behavior interventions. If glycemic targets are not achieved within 3 to 6 months of diagnosis, then basal insulin should be initiated. If targets are still not achieved on a combination of metformin and basal insulin, then pre-meal rapid-acting insulin should be initiated. The treatment options for type 2 diabetes in youth study was a multi-center trial that randomized 699 youth with type 2 diabetes to metformin alone, metformin plus a lifestyle intervention, or metformin plus rosiglitazone. The study population included youth 10 to 17 years of age with a mean diabetes duration of 7.8 months and an A1C of less than 8%. Treatment failure was defined as an A1C of greater than or equal to 8% over 6 months, or a sustained metabolic decompensation requiring insulin therapy. Treatment failure occurred in approximately 50% of patients on metformin. This suggests that treatment failure is common and that most youth with type 2 diabetes will require a second agent to manage their diabetes. Serious adverse events thought to be related to study medication were uncommon over the mean follow-up period of 3.9 years. Given the concerns raised around the long-term safety of rosiglitazone since the start of this particular trial, however, it is premature to recommend its routine use in children on the basis of this study. Immunization recommendations for children with type 2 diabetes are the same as for those with type 1 diabetes. Some children, however, may have other factors that place them at higher risk of increased influenza and pneumococcal-related morbidity, and these should be taken into consideration. Short-term complications of type 2 diabetes in children include DKA and HHS. 10% of Canadian youth present with DKA at the time of diagnosis of type 2 diabetes. High mortality rates have been reported in youth presenting with a combination of DKA and HHS at diagnosis. The management of HHS in pediatrics often requires more aggressive fluid resuscitation, delayed insulin administration at a lower dose, and careful replacement of potassium, phosphate, and magnesium. The management of DKA is similar to that for type 1 diabetes. Youth with type 2 diabetes appear to be at significantly higher risk of developing earlier and severe microvascular and cardiovascular disease when compared to youth with type 1 diabetes. Given this, we recommend screening for these complications at diagnosis and yearly thereafter. To screen for microalbuminuria, a first morning urine albumin to creatinine ratio is preferred. Abnormal results should be confirmed at least 1 month later with a repeat first morning albumin to creatinine ratio, and if abnormal, this should be followed by a timed overnight collection for albumin excretion rate. If albuminuria is diagnosed and is persistent, a referral should be made to a pediatric nephrologist. Aboriginal youth in Canada are at increased risk of renal diseases that are not associated with diabetes. Persistent albuminuria in this population may be evidence for an underlying renal disease, and a referral to a pediatric nephrologist for assessment of etiology and treatment is recommended. Children with type 2 diabetes often have coexisting cardiometabolic risk factors such as dyslipidemia. We recommend screening for dyslipidemia at diagnosis and every 1 to 3 years as clinically indicated thereafter. We recommend initiation of statin therapy if LDL cholesterol remains greater than 4.2 millimoles per liter after a 3 to 6 month trial of dietary intervention. Hypertension is common amongst youth with type 2 diabetes. Screening for high blood pressure should begin at diagnosis and at each subsequent clinic visit. Surveillance should also occur for other conditions associated with insulin resistance, such as polycystic ovarian syndrome and non-alcoholic fatty liver disease. Screening for neuropathy and retinopathy should begin at diagnosis and continue yearly thereafter. Screening for neuropathy involves questions on history, including symptoms of numbness, pain, cramps, or paresthesias, and on physical exam, looking at vibration sense, light touch, and ankle reflexes. Retinopathy screening can be done through digital fundus photography, direct ophthalmoscopy or indirect slit lamp fundoscopy through a dilated pupil, or through 7 standard field stereoscopic color fundus photography with the interpretation done by a trained reader. Screening for nephropathy and dyslipidemia should commence at diagnosis and yearly thereafter. Screening for nephropathy involves a urine albumin-creatinine ratio, preferably first morning, and if this is abnormal, it requires confirmation at least 1 month later with either a first morning albumin to creatinine ratio or a timed overnight collection. Repeat sampling should be done every 3 to 4 months over a 6 to 12 month period in order to demonstrate persistence. Screening for non-alcoholic fatty liver disease should begin at diagnosis and yearly thereafter. Screening can be done through the measurement of ALT or through ordering an abdominal ultrasound to look for fatty infiltration of the liver. Screening for polycystic ovarian syndrome and obstructive sleep apnea should be done clinically at diagnosis and yearly thereafter. The diagnosis of polycystic ovarian syndrome can be made based on clinical assessments and supportive blood work. Symptoms suggestive of obstructive sleep apnea include snoring, morning headaches, fatigue, daytime sleepiness, nocturia, enuresis, or observed apneas. Screening for depression and binge eating disorder should begin at diagnosis and yearly thereafter. Screening should be done through clinical assessments. The following are the agreed upon recommended guidelines for the diagnosis and treatment of type 2 diabetes in children and adolescents. Recommendation number 1, all children should receive guidance promoting healthy eating, limiting sugar-sweetened beverage intake, limiting screen time, improving sleep quantity and quality, decreasing sedentary behaviors, and increasing both light and vigorous physical activity to prevent type 2 diabetes. Recommendation number 2, children with obesity should receive intensive healthy behavior interventions that incorporate family-oriented counseling and behavior therapy to reduce future risk for type 2 diabetes. Recommendation number 3, screening for type 2 diabetes should be considered every 2 years using a combination of an A1C and a fasting plasma or random plasma glucose in children and adolescents with any of the following conditions. A, 3 or more risk factors in non-pubertal children beginning at age 8, or 2 or more risk factors in pubertal children. Risk factors include obesity, being a member of a high-risk population, having a first-degree relative with type 2 diabetes or being exposed to diabetes in utero, or the presence of signs or symptoms of insulin resistance. Screening should be done on all children with PCOS, impaired fasting glucose or impaired glucose tolerance, or those prescribed atypical antipsychotic medication for neuropsychiatric disorders. Recommendation number 4, if there is a discrepancy between the A1C and fasting or random plasma glucose result, testing may be repeated or a 2-hour oral glucose tolerance test may be performed. Recommendation number 5, starting at the time of diagnosis of type 2 diabetes, all children should receive ongoing intensive counseling including healthy behavior interventions from an interdisciplinary pediatric healthcare team that includes either a pediatric endocrinologist or pediatrician with diabetes expertise, a diabetes educator, and mental health professional. Recommendation number 6. Regular physical activity consisting of more than 60 minutes of moderate to vigorous physical activity daily should be recommended to all children with type 2 diabetes. Recommendations 7 and 8. The target A1C for most children with type 2 diabetes should be less than or equal to 7%. In those children with type 2 diabetes and an A1C greater than or equal to 9%, and in those with severe metabolic decompensation, insulin therapy should be initiated, but may be successfully weaned once glycemic targets are achieved. Metformin should generally be started at the same time as insulin unless acidosis is present. Recommendation number 9. In children with type 2 diabetes who are metabolically stable, with an A1C less than 9% and no or minimal symptoms, metformin should be initiated in conjunction with healthy behavior interventions. If glycemic targets are not achieved within 3 to 6 months of diagnosis, then basal insulin should be initiated. If targets are still not achieved on a combination of metformin and basal insulin, then pre-meal insulin should be initiated. Recommendations 10 and 11. Children with type 2 diabetes should be screened for neuropathy and retinopathy at diagnosis and yearly thereafter. Recommendation number 12. Children with type 2 diabetes should be screened for chronic kidney disease at diagnosis and yearly thereafter. The preferred method for screening is a first morning urine albumin to creatinine ratio. A random albumin to creatinine ratio can also be used. Abnormal results should be confirmed at least 1 month later with a first morning albumin to creatinine ratio or a timed urine collection. Albuminuria should not be diagnosed unless it is persistent, as demonstrated by 2 consecutive first morning albumin to creatinine ratios or timed collections obtained at least 3 to 4 months apart over a 6 to 12 month period. Recommendation number 13. Children with type 2 diabetes with persistent albuminuria should be referred to a pediatric nephrologist for assessment of etiology and treatment. Recommendation number 14. Children with type 2 diabetes should have a fasting lipid profile measured at diagnosis of diabetes and yearly thereafter. Recommendation number 15. Children with type 2 diabetes should be screened for hypertension beginning at diagnosis of diabetes and at every diabetes-related clinical encounter thereafter, at least biannually. Recommendation number 16. Children with type 2 diabetes should be screened at diagnosis for coexisting conditions associated with insulin resistance, including non-alcoholic fatty liver disease, obstructive sleep apnea, and polycystic ovarian syndrome in pubertal females. This should be done at diagnosis and yearly thereafter. Recommendation number 17. Children with type 2 diabetes should be screened at diagnosis for depression and disordered eating and at every diabetes-related clinical encounter thereafter, at least biannually. Here are a few key messages from the 2018 Diabetes Canada Clinical Practice Guidelines for type 2 diabetes in children and adolescents. Number 1. Anticipatory guidance regarding healthy eating, physical activity, limiting screen time, and age-appropriate sleep duration and quality is recommended to prevent type 2 diabetes in children and adolescents. Number 2. Regular and targeted screening for type 2 diabetes is recommended for those children at risk. Number 3. Children with type 2 diabetes should receive care in consultation with an interprofessional pediatric diabetes healthcare team. Number 4. Early screening, intervention, and optimization of glycemic control are essential, as the onset of type 2 diabetes during childhood is associated with earlier and more severe microvascular and cardiovascular complications. For those with children and adolescents with type 2 diabetes, there is plenty you can do to help manage or prevent type 2 diabetes in your children and youth. Encourage your child or adolescent to eat healthy foods, limit sweet drinks, get plenty of physical activity, and get a good night's sleep, and keep the time spent on screens low. All of this can help with the management and prevention of diabetes. Many children with type 2 diabetes will also require oral glucose lowering medication and/or insulin for treatment. The full guidelines, interactive tools, and other useful resources can be accessed on the guidelines website. The information is also accessible on the Diabetes Canada app available in the App Store and for Android.